Thanks, and I'm so glad to be here today to talk to you, all of you about this topic. And I was going to say, now for something completely different, but you asked the best question. So it's not so different. We're going to be talking about all sorts of disparities and reasons why those disparities might exist. So I happen to be a breast cancer oncologist at Mass General, and I've devoted much of my career in studying this issue. Sorry, I'm having trouble advancing. Is this thing on? There we go. OK, so we've made a lot of progress in the reduction of morbidity and mortality in breast cancer. And most people find this a success story, that over the last couple of decades, the death rate from breast cancer has actually been decreasing by 2 to 3% per year, although it has slowed in recent years. And a lot of that is due to some incredibly important new developments done by research and clinical trials that have really improved the survival and outcomes and quality of life in our breast cancer patients. And a select bunch of recent approvals are there on the right. But as you can see from this graph, while pretty much every racial and ethnic group have benefited from these therapies in terms of reducing breast cancer death, there is a really stubborn gap here between Black patients and white patients, in that we cannot seem to close that mortality gap. And the fact is, if you're Black and you have breast cancer in the United States, you are 40% more likely to die than if you're white with breast cancer. And that's what we're going to be talking about today. And breast cancer obviously still remains the leading cause of cancer death in women. The 5-year breast cancer survival rates by stage are shown here. So obviously, we always talk about the importance of screening for breast cancer, because the earlier you can find it, the better the patients do, and the higher the chances of cure. But as you can see here in the red column, pretty much by every stage, Black women tend to have worse outcomes in terms of survival, particularly when you get to stage 3 breast cancer, which is the locally advanced kind involving many lymph nodes or large tumors, and certainly stage 4, where the disease is already metastatic. So that's where a lot of the disparities exist at the later stages of breast cancer. So the other thing I want to note is in every state of the United States and the District of Columbia, there is a gap in breast cancer death between Black and white women. It exists in every state. And I'm from Massachusetts, so I'm proud that we're toward the bottom, actually. But if you look towards the top, Louisiana, 1.66 times more likely to die. District of Columbia, 1.5 times more likely. So this is something that I think is very, very important. And as we think, why should there be differences by state? You know, one of the obvious policy reasons is that Medicaid differs by state, and the ability to access Medicaid differs by state, and what Medicaid will cover in terms of care differs. So this is mainly an access problem, we believe, although there are other factors as well. But that's a huge contributor to this. And in fact, you can see, as you can show, as I say here, every state does see this, but there actually is no statistically significant difference in breast cancer death rates between Black and white women in 8 states, including Massachusetts. So I just have to say that because we're in Massachusetts. But numerically, it is worsened in every state. One of the reasons why Massachusetts might be doing better is that we have near universal health coverage here with insurance since 2004 or 6, when Romney Care actually went out, and that we actually have to have insurance if you're a Massachusetts state resident. So that might have been a big reason why there was an elimination of certain disparities in breast cancer to mortality. But what is the issue with the quality of care of breast cancer? Well, certainly dozens and dozens of studies have shown that there are racial disparities in the quality of care in breast cancer. And you name what we do in breast cancer, there are studies to show that racial and ethnic underrepresented minorities have worse outcomes. They're more likely to have delayed treatment after diagnosis. They're less likely to get adjuvant chemotherapy when indicated. They're more likely to have doses reduced from the chemotherapy for whatever reason, when we know that that really should be avoided if it can be avoided. They're more likely not to get endocrine therapy if they have hormone receptor positive breast cancer. And that's a real problem because that's really what improves survival and outcomes in hormone receptor positive breast cancer. They're less likely to have curative surgery or immediate reconstructions or reconstructions in general with plastic surgery. They're less likely to get radiation when appropriate. And they're less adherent to survivorship care, meaning coming in for follow-up visits so that we can determine whether they're on the endocrine therapy, if they're tolerating it well, if we're giving them what they need in the survivorship phase, which is a really big, important issue. And the poor of all races have similar patterns of disparate care. So that's been well documented. We really don't need these studies anymore. The other thing that I also want to touch on is that, you know, certainly over the last couple of years, we've talked a lot about structural racism. And we certainly have structural racism in healthcare. And I wanted to bring about this study, which my colleague Nancy Krieger did, that I think was really important. And what they found was that redlined areas, patients did worse if they had breast cancer. Now, what was redlining? That was a racially discriminatory practice that started in the 1930s when the federal government made maps for really banks to say, you know, is it safe for you to give loans to people who live in these areas? And if you had if you were in a blue and green area, it was safe to give. If you're in a red area, high risk. So color was determined in large part by the sociodemographic and racial makeup of these neighborhoods. And if you look in the city of Boston, you know, you've got Roxbury, Dorchester, Mattapan, redlined. So it was much harder to get a home loan to buy a house, for example, or a business loan to get your business off the ground. And this was a racially discriminatory practice. And in these redlined areas of Massachusetts, in our home state, it was certainly associated with a higher stage of diagnosis if you were a resident of those areas. And really in Georgia, huge disparities if you lived in a redlined area. If you're an immigrant who comes to the United States, how do you tend to do with breast cancer? Well, this is actually a map. I know you can't see it here very well, but darker means you have a higher incidence of breast cancer. So in the United States, we certainly don't do well. If you live in certain other parts of the world, you tend to do better. But if you immigrate to the United States, basically it takes 2 generations, but then the incidence goes to the same as the United States. So there's something happening here. It's not all just biology. There is something about lifestyle with variations in diet, growth factors, physical activity, childbearing habits that happen here. So I wanted to kind of give you bullets, because if you're taking a test about breast cancer disparities, like it's on the boards, for example, these are the kinds of things that you'll be asked. As far as incidence in the United States, there is a notable difference in the distribution of subtypes. If you're Black, you have twice as high a proportion of having triple negative breast cancer compared to other racial and ethnic groups. And certainly a lot of that is actually in younger Black women who are more likely to get triple negative disease. And that's obviously the most common, it's the most difficult type of breast cancer to treat because we lack a lot of the targeted therapies that are more effective, like endocrine therapy or HER2-based therapy. The incidence of breast cancer is increasing among Asian American women. And again, as I said, immigrant populations approach those of the overall US population within 1 to 2 generations. As far as breast cancer mortality, there continues to be a 40% higher rate of breast cancer mortality if you're Black versus white in the United States. But the mortality ratios by state are markedly different depending on what state you reside in. The stage of diagnosis is the largest contributor to cancer death, but doesn't explain all the differences. And there are multiple modifiable factors that contribute to the disparities, such as disparate access to care. So that's the facts. Now, what can we do? And that's what I think is sometimes lacking in some of these talks, because we really need to band together as a community to close these gaps. And there are concrete things that we can all do to do that. So first, policy. Things don't really get better in healthcare until there's major policy changes to make those changes happen. And a huge thing that happened in policy, obviously, over the last over a decade now is the Affordable Care Act. And that was signed into law by President Obama, has been upheld twice by the Supreme Court, so it is the law of the land, although there are some weaknesses to it now. But the the cornerstone of this law was to expand Medicaid so that you could improve access to care for the poorest Americans so that they could get health care. But it only works if you can actually do it, right? And this is the current state of Medicaid expansion by state, because with the last challenge to this law, every state was not obligated to expand Medicaid. And there are about 12 states that have opted thus far still not to expand Medicaid. And actually, that ended up exacerbating disparities even more in their states, because the way that the law was written, you could expand Medicaid, but then there would be, over time, there would be a decrease in direct hospital payments and other things. So if you did not actually opt to expand Medicaid, you're going to get hit twice or 3 times because there were some provisions in the law that happened to help fund this Medicaid expansion, actually. And that means that if you live in the states that didn't expand Medicaid, disparities could, in fact, be exacerbated, okay? But that is the current state in the United States. Now, is it so great, though, to have Medicaid expanded? Is there any evidence that it helps cancer outcomes, or certainly breast cancer outcomes? And the answer is yes, we do have evidence that Medicaid expansion is helpful. So in this study of breast, colorectal, and lung cancer survival, these investigators looked at Medicaid expansion versus non-expansion states to see if it made a difference. And in fact, they found that Medicaid expansion was associated with a significant decrease in mortality compared with non-expansion states, with an absolute survival difference of 0.4%, which doesn't sound like a lot, but these are hard studies to do, and this is the ultimate outcome of survival. We're not talking about recurrence. And over time, it would be expected that these numbers would improve. That basically means 250 patients with cancer would need to gain coverage for 1 death to be prevented, which is actually not a bad number. And there was a 2% decreased hazard of death. And in basic terms, at this stage, that means over 1,300 lives would be saved yearly if you expanded Medicaid, which I think is pretty remarkable, and that's just the 3 cancers. In Louisiana, there was another study looking where there are stark disparities that exist now. They opted to expand Medicaid in recent years, and actually they found that after Medicaid expansion, in breast cancer, that the percent or the proportion of patients diagnosed with earlier stage breast cancer, stage 0, which is ductal carcinoma in situ or DCIS, to stage 2 disease increased by 2%, and that the proportion of women who had later stage disease, like stages 3 and 4, decreased by 2%. And actually, Black women had more of a benefit compared to white women after this Medicaid expansion. So that was really good data that Medicaid expansion made a difference in the early years. So obviously, from an advocacy perspective, what we can advocate for is certainly Medicaid reform, that hopefully more states will expand it, but to strengthen what Medicaid actually covers. You know, what are those essential provisions that are needed to best care for cancer patients? And certainly, we advocated for and actually achieved that clinical trial protections should be covered by Medicaid federally, which was not the case until very recently. We wanted to make sure that there was parity between oral therapies, which we talk about a lot in this conference, versus IV therapies, because oral therapies go to the prescription benefit plans, which have worse coverage. We asked for a requirement of coverage of genetic testing, including molecular testing, and to reduce the variability between Medicare and Medicaid reimbursement. The clinical trial protection actually was a huge win in terms of advocacy, because I wanted to give you an example of this. A lot of us mobilized, went to Capitol Hill, and this act was actually passed into law in December of 2020, which mandated that all Medicaid recipients across the country had to have coverage for cancer clinical trials. And that was huge, because that did not exist before. Second recommendation, increase clinical trial participation, which got to your question, because that is critical to advancing how we improve our cancer outcomes and cancer treatments. So there is a vast under-enrollment in cancer clinical trials, no matter what race you are. You know, only 6% of eligible patients who would be eligible to go on a clinical trial actually enter, okay? And certainly, Black patients have far lower enrollment. Only 3% of industry-sponsored trials generally are Black subjects, and in SWOG intergroup trials, 9%. So intergroup trials tend to do a little bit better. But in the modern era of molecularly driven clinical trials, where we're finding these targets that are incredibly more promising, and when most of those treatments are only available in clinical trials, that means that this has become a social justice issue. The patients are being deprived of some of the best therapies that they can be offered. So this is a big deal. And if you look at the way we do clinical trials in the United States, it is no wonder that patients are under-enrolled in clinical trials, because structurally, we made it so that it's very hard to go on a trial. About half of patients get care in a place that there is no trial available. So that's already an issue. Another 25% of patients who would have gone on a trial can't because they didn't meet the inclusion criteria. So maybe their hemoglobin was like 7 or something like that, something goofy that needs to be not so narrow. So that means for more than 75% of patients with cancer, there are structural and clinical barriers that preclude them from even entering a trial. And that's worse if you're from an underrepresented minority background, because most of those sites of care don't have clinical trials. So that's going to be a major issue that we need to fix. And you asked a great question about, well, if you've got therapies that are being approved based on like 1% African American participation, what does that mean? It means that the results aren't generalizable, and we need to do better. And I could talk to you for another half an hour about that. So a third recommendation, prioritize research on interventions on how to actually reduce these disparities gap. Stop doing studies saying, oh, these disparities exist. We know they exist. Let's start doing something. Disappointingly few studies reveal interventions that work, so funding agencies need to prioritize this kind of work. We are doing some of this work in the Boston area. There's a collaborative called the TRIP Collaborative, where all of the academic medical centers in Boston, plus UMass and others, have actually gotten together and cooperatively decided to do work together. And I don't think there's actually a lot of cancer collaboratives where all the academic center says, yes, let's do something together. This is really something we're committed to. And what this collaborative does is it uses a shared registry, looks at social determinants of health together, and provides patient navigation jointly to improve cancer care for all of our patients together. And we're just starting to analyze the data. There have already been a couple of papers published, and we're looking forward to doing more for there. But we hope this serves as a model for other locations. So here are the top 5 priorities in reducing cancer disparities. Advocacy, that's huge, to improve access to care, with a particular emphasis on Medicaid reform. Increase minority enrollment to breast cancer clinical trials. Prioritize research aimed at interventions to reduce disparities. Improve education and awareness of cancer disparities among health professionals and the public. And getting out there and partnering with our community members, doing community outreach that's meaningful, and engaging those community members to more successfully build team-based approaches between academic medical centers, community oncology, primary care doctors, patient advocacy organizations, so that we can have more of a team-based approach to help our cancer patients. So with that, I'll take any questions. Thank you. Yes, question.
Just a very quick question. You talked a little bit about some of the potential causes for disparate outcomes in African American women, and one of the ones that I noticed was dose reductions of chemotherapy. And so I come from the South. I'm from Alabama and Mississippi. So we are in areas of the country where obesity is a tremendous problem. Mm-hmm. And in talking to physicians about how they dose chemotherapy, and in breast cancer care in particular, there is sometimes an inclination to cap dosing on anthracyclines, for example. Right. So tell me what you do in your own practice and what you teach your fellows about those issues.
I'm so glad you brought that up. There actually was an American Society of Clinical Oncology, or ASCO, guideline about treatment in obese patients. And the strong recommendation was not to dose reduce because that actually leads to poorer outcomes. So it is actually incorrect to dose reduce right off the bat for somebody who's obese. You should be dosing based on weight. You can dose reduce for toxicity, obviously, but not based on weight. So that's something that strongly should not be done and could lead to worse outcomes for these patients. So thank you for that question.
You talked about the registry that you have now. How are you getting into, I work in a community hospital in New York. How are you getting the university hospitals, because it seemed like the list was all university hospitals, into the actual community hospitals and getting them on clinical trials? What is like the mechanism that you're using to get them on?
So
I know it's a registry, but
Right, so that is such a great question. And I think that is the crux of how do we improve access for all types of sites to be able to get their patients on trial. And in Boston, for example, I don't know if they're, who's here or who's listening, but we have actually partnered with Boston Medical Center in a very meaningful way. In the city of Boston, that's a safety net hospital, really, burdened, underserved patient population, where we've actually had a policy and a legal agreement to be able to have virtual tumor boards with them so that we can talk about their patients, who's eligible. And the key is to form these partnerships with places where patients are actually getting their care in a respectful, collaborative manner. Because I think where we get into trouble from the academic side is when we're thought to be stealing your patient. That's not the point. The point should be respecting, knowing that standard care is amazing where they're getting their care. But for certain patients, they gotta know that there are other options for them. And so it's hard to do. But it's really important. Until we start doing that, we're not going to get anywhere.
Good morning.
Yes, good morning.
I just wanted to know, what is your strategy for these patients who come in who make it challenging when they are given recommendations? Like, for example, I have a 44-year-old who's had chemotherapy, was lost to follow-up by her own volition, came back, worse disease, did chemotherapy again, recommendation is for surgery, not going to surgery, recommendation now is just go into AIOA, and she's not doing that. So how do you handle those situations? Because does that contribute to any of this as well when you're educating them but they're not following those guidelines and recommendations?
So that's a great question, and that's something that we all deal with every day, right? And I think that, the biggest thing is to find out from the patient why. And there might be something very cultural. For example, a lot of our Haitian population, illness is not something that it's something that's suppressed, it's very secretive, and they're only going to seek care when they feel sick. So if they've got a mass and your treatment is working, you shrunk it, they might go away because they think it's better, let's not come back. So it requires constant reinforcement of what the goals are and allying with trusted other people, whether it's chaplaincy, depending on the culture, whether it's their primary care doctor. But the bottom line is that it takes time. And special populations that we all care about, the pregnant patient, the young patient, the older patient, the underserved patient, it's going to take time. And we have to reframe our thinking. But that's why a team-based approach is particularly important in the underserved patient population. Thank you.
Thank you